Well, good day, everyone. This is Chris at the Ancient Scholar. I know it's been a little while since I posted video, and I'm still about as busy as ever, as I've kind of explained in the last video I posted probably a little over a month and a half ago. Also, pardon my voice. I'm getting over the flu, so I'm still a little plugged up. But I wanted to go ahead and make a quick video, and this is in response to a conversation I had with somebody that I kind of used to fly with, and apparently he was talking to me about how where he's working, they have apparently changed their protocols in regards to ventilator management, specifically in regards to how they set initial tidal volumes on patients. And he was he thought this change was a little curious. In the past, all the patients that had been placed on a ventilator, we would initially calculate initial tidal volumes at 6 to 8 milliliters per kilogram, and that type of lower tidal volume is something known as a lung protective strategy. And we know through research done by ARDSNet that if we can do lower tidal volumes, we can keep a certain pressure, something known as the plateau pressure, something I've talked about on other videos here. If we can keep that lower than about 30 to 35, we may be able to prevent some of the complications associated with ventilator management, such as barotrauma, volutrauma, shearing trauma, and so on. And now, apparently, they are using 10 to 12 milliliters per kilogram for tidal volume on all their patients, and he found this a little interesting. So I just wanted to put a video out because, when I first learned how to do ventilator management, I calculated every patient at 6 to 8 milliliters per kilogram, put every patient on this quote-unquote lung protective strategy. However, let's be clear here. Let's kind of talk about this. Lung protective ventilatory strategies are good and are potentially helpful for patients that have underlying pulmonary issues, patients that have ARDS, patients that have a lung injury. If they have some underlying pulmonary issues, a lung protective strategy may be helpful. Now, if I have a patient that doesn't have an underlying pulmonary issue, maybe they weren't even ventilated, or they weren't even intubated and placed on mechanical ventilation due to a pulmonary issue. For example, maybe it was a trauma patient, had a head injury, who was relatively healthy, and didn't have any known pulmonary issues. Lung protective strategies on those types of patients may or may not be helpful. Some of the data I've seen doesn't really seem to indicate that initiating lung protective strategies on every single patient helps everybody, but certainly lung protective strategies are a good consideration in patients that have underlying pulmonary issues, because we want to limit the pressure that is encountered in the airway. Even recently, there is some discussion as to whether the plateau pressure is the definitive measurement for how well or how poorly we're ventilating patients, and I would tend to disagree with that. I think that managing patients on a ventilator is exceptionally complex. There's a lot that goes into it, and in my opinion, I think it's a bit myopic to rely on one number or one set of criteria for managing and assessing these patients. It's a very, very broad and broad subject. A lot of things can go on, and I think that we need to be very flexible in how we look at ventilator management. Now, certainly, I think assessing the plateau pressure, calculating compliance, and integrating that into the overall picture of the patient is a very good strategy. Don't get me wrong. I'm not saying that we should throw all that away, but I'm just saying that we can get ourselves into some trouble if we try to look at a specific value or a specific parameter in a vacuum. Okay, so with that said, what's my take on this whole tidal volume business? Well, my take is 10 to 12 milliliters per kilogram is not an unreasonable starting tidal volume, assuming a couple of things. Assuming one, that you're not dealing with some sort of pulmonary pathology. If you have different types of pulmonary pathology, you may want to modify that that somewhat, and a lot will depend on the patient. There are lots of different types of pathology that can obviously make us want to consider setting another tidal volume. So that's acceptable. I know in respiratory school we learned 8 to 12 milliliters per kilogram. We often would start at 10 milliliters per kilogram and then go up or down from there. The other point is a lung protective strategy. Not every patient needs to be on a lung protective strategy. Not necessarily. That's to say that not every patient needs to be at 6 mils or 5 mils. Some of these really low tidal volume strategies per kilogram. Lung protective strategies are, I think, a good consideration when we have some underlying pulmonary issues, but it's not necessarily a consideration for every single patient. Again, looking at something in a vacuum is probably not the best way to deal with such a complex concept such as ventilator management. Okay, so that's my take on it. The other thing that I really want to emphasize is if we are, regardless of what strategy we use, a lung protective or a conventional, traditional 10 to 12 milliliters per kilogram, I think we need to be very clear on what that 10 to 12 milliliters per kilogram encompasses. And it does not, and I want to say that I want to be very clear about this, that does not include actual body weight. Okay, we can get ourselves in some real trouble if we look at a patient and let's say they weigh 150 kilograms, and we get drawn into that 10 mils per kilogram. Well, that's a 1.5 liter tidal volume. Now clearly that's an extreme case, but the potential for someone to misinterpret what they mean there, I think that possibility exists if we're not very clear on what we calculate our tidal volumes on. So let me be very clear that when we calculate our tidal volumes, we need to go off of ideal body weight. Okay, we need to calculate tidal volume, be it a more traditional strategy, or be it lung protective strategy, or be it monitoring exhale tidal volume if you have somebody in pressure support, pressure control ventilation, or a specialty mode like bilevel APRV. Or even high-frequency ventilation, measuring the exhaled volumes in that case. We want to calculate our volumes off of ideal body weight, okay? You look at me, I'm kind of a big guy. I kind of have a little more adipose tissue than I probably should, and it doesn't seem to get any better as I get older. So it could be very easy to potentially give me a much larger tidal volume than I need. So you got to calculate your tidal volume, your initial tidal volume, base it off of ideal body weight. Okay, guys, I really just kind of dislike this whole look them up and down. Oh, that patient looks like they weigh 100 kilograms. So just base everything off of 100 kilograms. No, try as best you can to get a height on the patient and to do a good calculation and get at least as reasonably close as you can to ideal body weight, and then base your calculations on that. Because here in the United States, at least, in a lot of cases, if you go off of ideal body weight, you'll find that your tidal volumes are actually going to be a lot lower than if you base them off of actual body weight. Okay, guys, that's really all I have to say here, and it isn't anything that I haven't said in some of my videos, but I just thought it was really appropriate and something that I wanted to emphasize. To hopefully prevent any misunderstanding, and if people are maybe learning new things, to really be careful as to what the context is of the learning. So that's all I have right now, and as always, thanks for hanging in there, guys, and we'll see you next time.